Welcome to AJP Audio for December 2021. I'm Aaron Van Dorn. In this month's podcast, we'll talk to Dr. Samuel Wilkinson, Assistant Professor at Yale University and Associate Director of the Yale Depression Research Program. Dr. Wilkinson is an author on a study published in this issue of the American Journal of Psychiatry that looked at the effects of electro-convulsive therapy on all-cause mortality and in suicide in elderly Medicare patients with major mood disorders. Following that interview, Dr. Ned Kalin, editor-in-chief of the journal, will discuss how the December issue of AJP fits together. Dr. Wilkinson, patients with major mood disorder are at greater risk of premature mortality and suicide than the general population. Your study looked at the effects of electro-convulsive therapy, or ECT, on older Medicare patients with mood disorders. What did you find?
Well, we found that those who received ECT were substantially less likely to die over the year following hospitalization. There was some hint from prior literature that this was the case, and other studies had suggested this, but I think we were able to overcome a number of limitations from prior research and really, I think, show this in a fairly convincing and rigorous way.
ECT has a long and complex history, both as a treatment and in popular culture. Can you explain a little of that history?
When ECT came on the scene, it was really 1938 that is generally cited as the year it was developed. There weren't really medicines, antidepressants, antipsychotics had not really been developed yet. And so, it was used in large numbers of patients and probably some of them inappropriately so, but there wasn't really much else to offer them except for institutionalizing them in state psychiatric hospitals. So in the 40s and even part of the 50s, it was used extensively. And then when antidepressants and antipsychotics started being developed in the 50s and 60s, things swung back a little bit. I think it has a troubled history, just like all of psychiatry, but there were some abuses and misuses of it in the United States in the 50s and 60s. And then, with the 60s and 70s, during which kind of deinstitutionalization happened, and there was a big push for, along with civil rights, patient rights, and trying to get people who had been institutionalized living in the community. There was a kind of a backlash against ECT. People saw it as a cruel treatment. Of course, this movie, One Flew Over the Cuckoo's Nest, did not do much to help the image of it. Ironically, kind of nowadays, even though the depiction might be otherwise, it's kind of harder for people who are not of socioeconomic means or minorities and so forth. It's harder for them to access the treatment than, say, Caucasians who are of some affluence and so forth. I think for a long time it was thought, oh, this is just used to punish minority patients, those who are poor and so forth. That's definitely not the case now. I don't know exactly if that was the case in the 60s and 70s, but there's definitely been a lot of, I think, some poor depictions, some of which were founded in past practices that were not great. Certainly here in the United States, nowadays, it's not used as a form of punishment or anything like that. It's used as a medical treatment for severe psychiatric disease and sometimes related medical disease. So, there's quite a bit of history. Cultural history of the back and forth of ECT, and certainly the techniques are better. So, one of the biggest problems with ECT is the fear of cognitive side effects, the fear of memory problems, and a number of people over the years have substantially improved ECT techniques to reduce the risk of those memory problems and made it so it's much safer. That's just a little bit of the history of ECT and the pushback and the push forward, and really, I think the vast improvements in technique that have gone on in the last 80 so years.
You mentioned that prior studies suggested that ECT might reduce all-cause mortality, but studies into the effects of ECT have often had major limitations. Can you discuss the limitations of past research and how your study tried to address them?
I think one of the biggest limitations of prior past research is the issue of confounding by indication. So most studies with which I'm familiar did not try and control for differences in kind of baseline medical issues between patients who received ECT and those who didn't. If you showed that the patients receiving ECT had a lower rate of death, it could just be because they were healthier to begin with. Now, that may not necessarily be the case, but if you don't try and adjust and control for it in ways that make sense, then you're not sure what you're getting. Patients who received ECT, they may have been healthier, and that may potentially be why they got ECT. If an anesthesiologist says, well, this patient's really sick, they've got this respiratory condition, I don't think it's safe for them to get ECT, so we're not going to give them ECT, and then that patient is more likely to die anyway just by baseline. So it's a major issue in all observational studies, this issue of confounding by indication. And you can never be completely sure that you've adjusted for it just by nature of observational research. But I think we did the best we could given the databases that we had. I think another strength of our study is the fairly large sample size. So we looked at roughly 40,000 patients, 10,000 of which received ECT, 30,000 of which did not. And they were really fairly well matched in a number of really key factors that are associated with both suicide risk as well as just general mortality risk.
How did you go about the matching process? What was involved and what were you looking for?
We set out beforehand, before we'd actually really delved into the data. We basically chose, of all the factors that were available, we chose to exact match on the factors that we thought would most affect suicide risk and as well as general mortality risk. So, basic things that are often controlled for: gender, age, and so forth. In addition, we were able to control for past suicide attempts in the prior 12 months, in the past psychiatric hospitalizations in the prior 12 months, and something called an Elixhauser score, which is a marker for general medical mortality. These things were exact matched across groups that I think really strengthened the study. Now, there were other variables, your finite population. You can't exact match for everything. And so there were a few variables that we couldn't exact match for, but those were adjusted for in what's called the Cox proportional risk models. Things like, the prior medication use in the past year, although those were fairly well matched anyway. We really did all that we could to either exact match or adjust for a number of variables.
The paper mentions that there are some limitations to your study that needed to be commented upon. What were those?
So again, probably the biggest one is just the general nature of observational research. The only way you can really be definitively sure that your intervention is causing a given outcome is if you run a randomized trial. But the problem is that there's no way I can foresee in the near future that we're going to be able to run a trial that is large enough to capture these kinds of outcomes, which are fairly rare, things like death and suicide. As I noted before, there's about 41,000 or so patients in this observational study. There's studies that big that are trials, prospective trials, are just exceedingly rare and just obviously very, very expensive. So that's probably one of the limitations. Another limitation, again, is that we could not exact match for everything. We adjusted for things, which is good, but we could not exact match for everything, just by virtue of the nature of finite populations.
What does your research suggest for treatment of patients going forward?
I think a lot of us who do research in ECT think that ECT is probably not utilized as much as it could be or it should be. ECT is really only available in about 10% of psychiatric hospitals. So there may be a patient who could really benefit from it, but just by chance they end up at a hospital that doesn't offer it, and when that happens, they're much less likely to get it. And again, according to this paper, for older patients above age 65, ECT can be associated with a much lower risk of death in the year following hospitalization. So I'm hoping that this will just continue to spur a conversation on, how can we, even though ECT is really hard to implement and an ECT service is hard to get up and running and to maintain and so forth, I'm hoping that this can be just further evidence that it's an important treatment we need to pay attention to, despite the fact that it's been around for a long time. It has continually improved in its techniques and lessened the risks of cognitive side effects and other side effects over the years. So I'm hoping this just continues to add to the literature that, look, this is a really important treatment, and it should be offered at more hospitals so that we're not missing patients who could benefit substantially from it.
You mentioned that ECT is only available at about 10% of psychiatric hospitals, and the article discusses the difficulties of accessing and administering ECT. What causes those difficulties and how can they be improved?
Some centers have quite a bit of difficulty as patients transition from inpatient to outpatient status, and it's hard for them to continue care. And a lot of that is just the administrative challenges of their local hospital. Sometimes, if a patient lives 2 hours from the hospital, once they go home, it's just much, much harder to get the treatment as opposed to actually being in there in the hospital overnight. In big states in the Midwest and the Mountain West, or where you have these huge driving distances, that's an issue. I think, again, just trying to make it so that this is available at more centers, get more people educated about this. Some of these authors and I published another paper just a few months ago in Psychiatric Services, which is another journal of the APA, looking at reasons that it was hard to start or maintain an ECT service. And one of the bigger reasons, one of the most common reasons, there's just not enough people educated in this. If you could educate people, that paper suggested that you could profoundly influence the availability of this if there were more of an educational push to say, okay, let's get people competent in this fairly unique modality. That would do a lot to kind of relieve the pressure and enhance the availability of this.
What are the next steps in research into ECT in patients with elevated suicide risk?
So our paper showed that up to the first 6 months or so following hospitalization, ECT was associated with a lower risk of suicide, which is great. Other papers that were actually published around the same time also suggested a protective effect against suicide. There have been some papers that haven't quite shown that, and despite the fact that this had a huge sample, I think we really need to kind of dig into this and just keep kind of refining and improving the techniques of these types of studies to say, okay, it looks like this can be protective for some patients. It may not be protective for all patients. Can we kind of figure out beforehand what type of patient it would be effective for? I think that would be a very valuable thing. I think another thing, not necessarily with respect to suicide, but with the all-cause mortality, which shows a more substantial and durable protective effect that is associated with ECT. I think the next steps there are to figure out, okay, why is ECT associated with low risk of all-cause mortality? Is it because patients who are just severely depressed, once they get ECT, they're just much better. They're better able to take their medicines, go to their follow-up appointments, take their blood pressure medicines, their diabetes medicines, and is that the kind of the mechanism by which ECT might be reducing the risk of general mortality? So there's a lot of, I think, exciting kind of avenues to further explore and hopefully, further bring this to clinical practice and expand this for the betterment of patient care.
Dr. Wilkinson, thank you for taking the time to speak with us today.
All right, I appreciate it. Thanks for having me.
Next, I spoke with Dr. Ned Kalin, Editor-in-Chief of the American Journal of Psychiatry, about the December issue of AJP and what it contains. Dr. Kalin, welcome back to AJP Audio.
Thank you. Pleasure to be with you.
The December issue of AJP features articles that offer new insights into major depressive and bipolar disorders. What can you tell us about those articles, and what does it offer on treatment for those conditions?
The December issue is focused on depression and bipolar disorder. Obviously two very important conditions that comprise a lot of what we do in psychiatry from the standpoint of our patients. And the papers that were selected to either shed new light on the understanding of what's going on with these illnesses and or to also help us think through new ideas about outcomes and treatment. And there's some very, very interesting papers, starting with a review on neuromodulation strategies. There have been major advances in relation to using such things as transcranial magnetic stimulation with different parameters, and as well as a variety of other neuromodulation strategies, including deep brain stimulation, all of which are reviewed in this issue, which really, I think, gives a nice overview for our readership of the available modalities, a little bit about their history and a little bit about how they work and what you can expect from the standpoint of outcomes. Also talks about what's in the future as far as future developments may be. Another really interesting paper is related to ECT outcomes in older patients related to all-cause mortality, which I know was already discussed in the podcast. But this is really important from the standpoint of demonstrating that in older patients, ECT appears to have an effect on decreasing mortality over the first year after a treatment episode with ECT, and also reducing suicidality on the shorter term. So this is interesting from the standpoint of both reducing mortality and also having relatively brief effects, unfortunately, on suicidality. Our hope would have been that we would have seen data that would have extended beyond this shorter time point from the standpoint of reducing suicidality. And I should say that suicidality reduction was seen up to 90 days after ECT treatment. Important to emphasize that in patients that are struggling with suicidality that have ECT, that while they may appear to get better, that this could be an effect that is not as long-lived as we would hope to see it. Another paper from the standpoint of treatment issues is a paper that presents data from a phase 3 multi-site double-blind study looking at a antipsychotic medication, Lumateperone, that is currently approved for treating schizophrenia, looking at data for the treatment of major depression in bipolar I and bipolar II patients. Bipolar I and bipolar II patients, as we know, are distinguished by bipolar I patients having true manic episodes and bipolar II patients not having full manic episodes, but rather having hypomanic episodes that are interspersed with depressive episodes for both bipolar I and bipolar II disorder. Bipolar depression in general, which is major depression occurring in a bipolar I patient or bipolar II patient, can be particularly difficult to treat. And we don't have a lot of approved therapies for this. So there's a need here. Basically, what this paper showed was that by using this atypical antipsychotic or second generation antipsychotic that has various effects on binding at a bunch of different neurotransmitter receptors, some serotonin receptors and dopamine receptors, as well as the serotonin transporter, that there was a significant reduction in depressive symptoms in the treatment group that received 42 milligrams per day of lumateperone compared to placebo over a 6-week period of treatment. Having said that, when you look at how many patients that get into remission, when you compare lumateperone to placebo, the effect is not all that large. It's a comparison of 39.9% to roughly 33.5%. That's not to say that this is not important, but it's not as big an effect as we would like to see in many cases. Nonetheless, this really shows that this approach may be fruitful from the standpoint of working with what's generally a hard to treat condition, bipolar depression. They also looked at side effects and found minimal side effects in this trial, but keep in mind that this was a relatively short trial and that many of the side effects that are associated with atypicals take longer to manifest. There's a really nice editorial by Dr. Michael Ostacher from Stanford University who further talks about this and also points out that the numbers of patients in the bipolar II group are relatively small. So we should be careful in drawing generalizations across both bipolar I and bipolar II patients from the standpoint of the outcomes of this study. No question that this is an effect that's seen in bipolar I. The question would be, since the sample size is smaller for bipolar IIs, is this effect really there in that group? Another area of marked interest over years has been understanding how inflammation interacts with depression and anxiety and other psychiatric problems. And there are a number of predominant theories about how inflammatory processes in the body and in the brain are related to alterations in neuronal function that then can be reflected in changes in mood or mood regulation. A study that we published in this issue of the journal looked at a very, very large sample of individuals, an analysis looking at combining a variety of different population cohorts and looking at the question of whether or not peripheral markers of inflammation, things like C-reactive protein and interleukin-6, are related to individual differences in depression. And more importantly, these authors asked whether there are different symptom subtypes that are associated more or less with these inflammatory markers. And one of the very interesting things that they found was that there was a relationship between, for example, CRP levels and depression, but the symptoms that were most associated with this were the symptoms that we tend to think of as the physical symptoms of depression. So for example, things like changes in appetite, feeling like there's one doesn't have any energy, not being motivated, sleep problems, and so on, were symptoms that when they were endorsed that were more highly predictive and correlated with the inflammatory markers. whereas emotion-related symptoms, like things like sadness, were not significantly correlated with some of these markers, suggesting that the inflammatory processes may be linked symptomatically to more types of symptoms that we think of in relation to other illnesses. When people are sick, they feel lethargic, they don't feel motivated, they can feel down in the dumps. So we call that sickness behavior. And the findings from this paper suggest that there may be subtypes of symptoms that are more related to inflammation and maybe, in fact, more mediated by inflammation. This is interesting because it begins to get to the idea of more personalized medicine approaches or psychiatry approaches and thinking about subgroups of patients. It might be, and this is speculated by Dr. Carmine Pariante in his editorial, that if we were to target inflammatory processes in depression, that the patients that have these somatic symptoms and also have high levels of some of these inflammatory markers might be the ones that would be most responsive to interventions that were focused on anti-inflammatory processes. So quite interesting from the standpoint of the finding, interesting from the standpoint of subsets of symptoms and implications as we move forward about subgroups of depressed patients that might be more responsive, in this case, to approaches that are targeting inflammatory responses. And then finally, a paper looking at brain structure in earlier life depression and later life depression is interesting. And this is interesting because it really gets into trying to understand whether there are different brain structural alterations in people that have early onset of depression versus the subset who have late life depression. And it's important to keep in mind that when we're talking about late life depression, we're really talking about the onset of depression later in life, not necessarily having a depressive episode later in life per se, because the typical course of recurrent depression is to have early depressions early in adulthood through mid-adulthood and then even into later life. We're talking about that as recurrent depression that starts early. When we talk about late life depression, we're talking about depression that comes on later in life. The reason that's an important distinction is because there may be different pathophysiologies that underlie later life depression from depression that manifests earlier in life. And one of the prevailing ideas has been that late life onset depressions is more related perhaps to cerebrovascular disease and cerebrovascular changes in the brain that may be mediating some of these depressive-like effects as compared to different types of pathophysiology that occur earlier in life. And in fact, the researchers found that there were some brain structural alterations that were both shared between younger onset and later onset depressives, and also some differences in brain systems and brain structures that shed some light on these differences in late life depression. So I think, taken together, the papers in this issue, as I mentioned, are really bringing up important issues that hinge on understanding more about the underlying science that then allows us to think about new treatment strategies. As I mentioned, the paper on neuromodulation highlights a variety of approaches, including a new approach called theta burst, which looks like it's going to be particularly effective for RTMS. The paper related to ECT and all-time mortality talks about reducing mortality over the first year in elderly patients, but only having somewhat of a transient effect in relation to their suicidality. New data regarding an atypical antipsychotic is being helpful for the treatment of patients with Bipolar I and Bipolar II depression. Interesting data related to inflammatory markers and thinking about subsets of patients as we move forward with new novel treatment strategies, in this case, perhaps an anti-inflammatory strategy. And then finally, understanding some of the brain structural differences in early onset versus late onset depression that may give us some ideas about differential treatment across those two different age groups when depression presents. So I think in summary, we've got a really nice group of articles here that are informative and hopefully will be useful to our readership.
Dr. Kalin, thank you for helping to put this issue into context for us.
My pleasure.
APA Publishing has other podcasts you can listen to. From Pages to Practice looks at the latest research published in the journal Psychiatric Services, hosted by Dr. Lisa Dixon, editor-in-chief of the journal, along with Dr. Josh Berzin. AJP Residence Journal, a podcast by and for medical students, psychiatry residents, and fellows. And finally, Psychiatry Unbound is the books podcast from APA Publishing, hosted by Dr. Laura Roberts, editor-in-chief of APA Books. Check out these and others along with APA's newest podcast, Mentally Healthy Nation, at psychiatryonline.org/podcasts, or you can subscribe via Apple, Google, Spotify, or wherever you find podcasts. The views and opinions expressed in this podcast are those of the individual speakers only, and do not necessarily represent those of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.